Well, hello everyone and welcome to our webinar. Thank you for joining us on this webinar today so that we can focus together on how to improve home care outcomes for diabetes and stroke patients. I am Emily Eberly and I'll be your moderator. And also behind the scenes today, I'll be processing the incoming questions from all of you in the audience and facilitating a special live Q&A session towards the end of our presentation today. And this webinar is accredited for 1 contact hour of continuing education for nurses. The title of today's session is Using Oasis to Improve Home Care Outcomes for Diabetes and Stroke Patients. Speaking on this very important and timely topic is Lisa Gorski. Lisa received her MS from the University of Wisconsin, Milwaukee College of Nursing. A clinical nurse specialist at Wheaton Franciscan Home Health and Hospice, Lisa is also a Fellow of the American Academy of Nursing, past president of the Infusion Nurses Society, and the current chairperson for the INS Standards of Practice. A highly sought-after speaker, Lisa has spoken at numerous nursing conferences both in the U.S. and internationally, and as well she has published over 50 articles in peer-reviewed journals. We do wish to acknowledge the following disclosures. An honorarium has been provided by Covidian for this presentation, and Lisa discloses that there are no conflicts of interest in the development of or presentation of this webinar. And now here's a very warm welcome to our speaker, Lisa Gorski. And Lisa, it is certainly a pleasure being here with you yet again today. We've shared a number of webinars together, and I've enjoyed working with you each time and as well as we've prepared for this webinar. Are you ready to begin the presentation?
I am ready. Thanks so much, Emily, for the introduction, and it's been a pleasure working with you as well. We'll go ahead and get started. The objectives for today's webinar, that after attending this presentation, you'll be able to describe Oasis assessment data critical to complete in the initial home care visits for patients who have had a stroke and diabetes, to explain the importance of medication, skin and falls risk assessments in this patient population, to describe how to utilize Oasis assessment data into care plan development, and to explain the importance of often minimized pain and depression assessments as part of Oasis. There we go. Okay, slides are moving now. Oh, skipped ahead. Okay, so in terms of introduction, you're all familiar with Oasis, which is the acronym for Outcome and Assessment Information Set. We've used this instrument and data collection tool since 1999 for Medicare certified home health agencies. And 2010 was the first major Oasis revision to the Oasis C. And the major change at that point was certainly there were changes in some of the Oasis items, deletion of some, addition of some, but one of the more major changes was the addition of a number of process outcomes. For example, assessment of falls risk, pain, assessment of pressure ulcer assessment. So looking to see that we have evidence-based practices in place to identify risk factors and potential problems among our home care patient population. The purpose of Oasis is listed on this slide. Certainly we know that Oasis is used to establish reimbursement through calculating the home health prospective payment case mix. We certainly do use Oasis in developing the plan of care, and it's also used in quality measurement in calculating potentially avoidable events through the creation of an OBQM report. Some examples of things that might be included in that report would be, development of a urinary tract infection, emergent care for hypo or hyperglycemia, emergent care for an injury caused by a fall. So there's a number of potentially avoidable events that are calculated based on Oasis assessment data for your agency. Outcome measures are calculated. For example, dyspnea. We evaluate dyspnea at start of care and resumption of care. and then at discharge as well. So to see if there's an improvement, for example, in their level of dyspnea. That's an example of a patient outcome measure. And then we have our process-based quality improvement measures. For example, to what extent does your agency do pressure ulcer risk assessments or falls risk assessments? And some of these, of course, are publicly reported on the Home Health Compare website, which is a Medicare website. And we can certainly access that and look to compare our outcomes to perhaps our competitors, but it was really intended for the public, for patients, family members, to really look at the organizations in their area, and perhaps they would use this information in terms of decision making for the agency that they choose to work with. As we move on here, just a little bit of a, kind of clarification. We're going to talk about Oasis in the context here, but it's not a lesson in how to complete Oasis. I'm not going to go through the instructional things, but it's more about how to use Oasis in care planning. And I'm not going to be looking at all of the Oasis items, but basically the ones that are, pertinent to the disease processes that we'll be discussing in this presentation today. And then just to let you know that this presentation was really developed off of a couple of articles that one of my colleagues wrote for the Safe Practices in Patient Care newsletter, Mary Narayan, from the Virginia area. She actually wrote these articles. We translated them into a webinar. Okay, so we're going to focus on diabetes and stroke, and I guess the question is why. Stroke, of course, is probably not the most prevalent diagnosis out there, but as we continue to see that shift of long-term care from acute and transitional care settings to home care, this is a significant population, and it's a complex condition that generally does require interdisciplinary care, and the role of the nurse is extremely critical in overall care coordination. Diabetes, of course, is very common. I would suggest that it's probably maybe the most common diagnosis among our home care patient population. Where maybe it's not the most common primary diagnosis, but it's a secondary diagnosis for so many of our patients. And we certainly see many home care referrals for the complications of diabetes, probably most commonly the diabetic wounds that we see that require long-term management, but as well as we're seeing these patients for overall primary disease management as well. And the home care nurse, again, plays a very important role in patient education and coaching. Okay, so when we look at, providing care in home care, one of the things that Mary talks about is the importance of trying to, do that initial assessment over 2 visits. And this is something that we do in my agency as well, for our high-risk patients. We go 2 days in a row to try and, capture everything. There is a lot to assess for a home care patient. There's a lot to do. And if we can stretch it out over a couple of days, it really is helpful and helps us develop a more comprehensive plan of care. But just as a reminder, the date assessment completed would be the last date when that final assessment are collected, which is an Oasis item. And technically, we know that we actually have 5 calendar days to complete the initial admission and start of care assessment. So that's the regulatory piece. Organizations may allow less time to complete that. But the first visit is really, to ensure the urgent patient care safety needs, the urgent nursing needs, while just beginning to establish, rapport with the family and trust. And top priorities when we look at that first visit, medication reconciliation is a big one. It's very important to spend time, and I've got a couple of slides on this later, but it'll help to, confirm or uncover any comorbidities as well. We may not get a complete diagnosis list depending on how the referral comes through, but taking a look at our medications will help to look at what are all the diseases and diagnoses pertinent for that patient. We want to confirm it's the correct medication and administration, especially for our high-risk drugs, and we know that is addressed in Oasis as well. And our patients with diabetes and stroke are often on high-risk drugs, including our warfarin, obviously, and hypoglycemics as examples. We're going to perform that physical assessment, and of course, if there are prescribed treatments or medications, we're going to do those on that first visit as well. Wound care, perhaps the patient is receiving IV antibiotics for an infection. So this is just an example of how you might divide Oasis data collection into the 2 visits. First one, focusing on meds, assessment, areas of concern by disease state, and some of that risk reduction assessment can be initiated. And you may finish that at the next visit depending on the patient situation. In the second visit, continue more in terms of the socio-demographic and medical history. Oops. Lost my spot there. Pain assessment might defer to the second visit. It may be an urgent patient need that needs to be addressed right off the bat. Depression assessment, which I'll talk more about later, is an important aspect of assessing these particular patient populations, really any chronically ill patient. And then really developing that care plan, finishing it, and discussing what the plan of care is with the patient and family. Sometimes I think we don't do enough of that. We kind of develop our care plan, but if we really put forth a discussion with the family that these are the issues that I see, based on my assessment, and these are the things that I think we should work on. Okay, there we go. Sometimes my buttons are a little slow to respond there. So if we look at diabetes versus stroke in that first home care visit, what are some of the priorities? Post-stroke, often we see higher levels of physical care that are needed because the patient has some functional limitations, and more time is probably spent assessing and their functional needs and the need for in-home multidisciplinary rehabilitation support. Certainly, oftentimes these patients will come through with referrals for multiple services, perhaps not, and we will need to determine that based on the initial assessment. For patients with diabetes, that first home care visit is really going to vary. A lot may depend on when that person was diagnosed with diabetes. Is it a recently new diagnosis with all new medications? We may spend more time with that. Perhaps it's somebody who's had long-term diabetes, but the complications of and there's been issues in terms of their overall self-management of, say, glycemic control. Commonalities in that first visit for really probably any patient with a chronic illness, but we're going to do that head-to-toe physical assessment. We want to do a very careful skin assessment on both populations where there are serious risks for skin integrity. Pain is a problem often with both of these patient populations, depression screening, and then some of the other risk reduction assessments as well. And I will talk a little bit more about falls risk later. However, as already talked about, not all of this can or should be done in the first visit. And depending on how that patient comes out of the hospital, they're fatigued, they're tired, their tolerance for a lot of time spent during the visit may be limited. So, it can often be more successful to extend that over a couple of visits. So, again, you can customize the emphasis based on the priorities that are maybe higher in one patient versus the other. Obviously, neurological assessment is a priority in stroke. Cardiovascular is a priority in both. Elimination could really be a priority in both, but certainly there may be issues of incontinence, difficulty eliminating in patients with stroke. Falls risk really should be a priority in probably all of our chronically ill populations, our older adults. Big function on ADLs and instrumental activities of daily living for the patient with stroke, and nutrition as well. Whereas a diabetic, we need to look at vision. For example, if they just came out of the hospital and they've had significant hyperglycemia, their vision can be, adversely affected for a while. So that's going to be an important thing to assess, especially if they're, in relation to their self-care management, checking blood glucose levels, administering their insulin, etc. Medication assessment. As I mentioned before, I wanted to spend a little bit more time on this. And this is so important for all of our patients. One of the things that I do in my agency as a clinical nurse specialist, I do see some patients out there, but probably more so, work with the nurses and our staff. And I look at the hospitalizations. I actually analyze the 30-day readmissions to the hospital to look to see, what are the problems and what are the things that we might have done to mitigate, or reduce the risk for that rehospitalization. I've been, doing this for a couple of years, and we've got, quite a database looking at, potentially preventable areas. We do know that medication mismanagement issues are a common reason that patients go back in the hospital, and that's why we really need to spend time, and it is time consuming. I think we can all attest to that. But taking the time to really look at everything, do they have it? Do they have an accurate list? I think people are much better in our hospitals these days at, sending forth that list, but then we get home and they have all these additional medications, and we have to take a careful look. Patients take a lot of over-the-counter things, whether it be just medications, vitamins, herbal supplements, and they don't always necessarily give you that information up front. So it's helpful to even ask some questions. Okay, if you get a headache, what do you do? If you have a stomach ache or diarrhea, do you take any other things, to get a sense of, what are the over-the-counter meds? If they have trouble sleeping, an important question for our elderly population, because there's a lot of over-the-counter sleep aids, and they mainly contain Benadryl or diphenhydramine, which is really contraindicated for the older adults because it is associated with increased risk of, confusion and falls, and they should not be taking that. So we want to, do that comparison and reconcile. And very importantly, and this evolves really over a few visits. It's sometimes hard to get a handle on this in 1 or 2 visits, but, looking at their adherence and what are their potential barriers to adherence. Is it, physical impairments, for example, dexterity? Let's look at the patient with stroke, or maybe the patient with some neuropathy. This can be a problem. And one of the things I see is a lot of nurses really like blister pack meds. And I'm not necessarily a fan. I don't think that works for a lot of people, especially when there's a lot of meds. It takes a fair amount of dexterity, and sometimes you break the pills as you push them through. And if they have a lot of pills, it takes a lot of time to empty all those out. My father-in-law, we recently moved him here, and he came out of a subacute care setting, and they sent home everything in blister packs. And he, he's in his 90s, and he's cognitively not too bad at all, but dexterity-wise, there's no way he could have handled that. So, in his case, it's easy for me to set everything up in a pill tray, and he can take things that way. So we have to look at, some patients may love it, but let's just make sure that it works for them. Cognitive and behavioral impairments. If there's impaired memory, there are cognitive issues. There's impaired judgment, fear, perhaps, of taking pain medications. All these things are going to affect adherence. Vision, as I mentioned before, pain, and then environmental barriers. That patient who has had a stroke and mobility is limited, making sure that things are stored in an accessible area. They don't have to reach, and which might perhaps increase the risk of falls. So there's a lot to think about, in terms of assessing adherence. Again, I don't think all of this can be done on that initial visit, and you can't always really get a full picture of what's going on until you've been in there a while. But these are things that we want to look at, because obviously not taking their meds correctly or adverse reactions are going to be contributors to their patient going back in the hospital. And our overarching goal is to keep them home and safe in the community. We want to, provide education. There is a focus in Oasis that we address our high-risk drugs right off the bat, because they're high risk. And again, as I mentioned before, warfarin and the hypoglycemic drugs fit into that category. So we want to prioritize that. And then, talk to the physician regarding medication discrepancies. And what's not on the slide, of course, are potential drug interactions that may result in problems as well. So medication assessment is a huge, important area of home health nursing. When we look at medication and symptom control in patients with diabetes, we want to look at, is their disease under control? We can look at, the daily blood glucose monitoring results, but we really want to look at their A1C level because this is going to be reflective of their long-term blood glucose management. Of note, in general, we're looking at less than 7% is an overall guideline, but for older adults, that the Geriatrics Association has put forth some guidelines that are a little bit broader, a little higher guideline in terms of A1C level, less than 7.5% in healthy older adults with a longer life expectancy. And it may be higher in those who have multiple comorbidities and shorter life expectancies because there probably isn't the concern for some of those, long-term complications, and there's greater concern over hypoglycemia, which can be of a concern in our older adults. We're going to look at the manifestations of their disease, of the diabetes, in other words, the complications. There's a note there, long-term insulin therapy would be a diagnosis for patients on insulin. Skin assessment is extremely important, as I reflected on earlier, for these patient populations. Both patient populations may be at risk for pressure ulcers, particularly the patient with limited mobility who needs assistance to move. Diabetic ulcers aren't listed here, but pressure points in patients who don't necessarily feel they have neuropathy. Stasis ulcers, they may have some venous disease as well, surgical wounds, and any other skin abnormalities and lesions. It's important to do a thorough skin assessment. In patients after stroke, of course, pressure ulcer risk assessment is an important thing to do. And this is where, I always like to talk about the fact that we don't just identify the problems that the patient was referred with, but the purpose of having some of these process Oasis items is to identify those at-risk problems. And for the patient with limited mobility, pressure ulcer risk assessment is a real potential problem. And we want to be able to name that. And we're going to, develop a plan with the patient and our family or caregiver to reduce risk. And we're going to look at the specific areas of risk. We may use a tool. Perhaps they don't have incontinence issues, so we're not going to really focus on moisture, but it's really activity and nutrition. On the other hand, they are having incontinence issues, which we know is going to contribute to potential skin breakdown, so we want to focus in on that area. So very individualized care based on those specific areas of risk. I'm not going to go through all the functional assessment items, but one of the positive things of Oasis, challenging at times to complete all of these items, is the functional assessment. You can see listed here, we're going to look at, where is their function in terms of grooming, dressing, both upper and lower body, bathing, transferring to the toilet, and performing toileting hygiene, cleaning up, transferring, walking, or locomotion if they don't walk, feeding or eating, ability to prepare light meals. So these are really important assessment items, and they particularly may be pertaining to that patient who, after stroke, who may have some significant functional limitations. We want to look at prior functioning, look at the changes from before, to now, and that's going to help us develop the plan of care and ensure that we have the right disciplines in place to manage that patient's care. Elimination assessment is critical for stroke patients as well, because there may be problems with urinary incontinence. Dehydration is sometimes a problem as well. And in fact, in my work looking at, I don't know how many hundreds of record reviews I've looked at over the past couple of years for 30-day rehospitalizations, I actually see dehydration as a somewhat common reason that patients go back in the hospital. We're really not identifying the risk for that. It's something that we really can intervene if we identify it as a potential problem and really monitor intake and, what are the problems that might contribute to it. Some patients might not drink enough because it's hard to go to the bathroom. They might not be taking a diuretic because they don't want to go to the bathroom too often. So these things, can contribute to fluid volume problems out there. So we want to really, look at overall elimination. What's not listed on here, urinary tract infections are very common, not only in our patients who have catheters, but in those who do not as well. So we want to monitor for that. And sometimes it's difficult. Patients don't necessarily have a high fever or something that's really obvious. It may be more subtle. So looking at skin care in patients who have diabetes, some of the considerations that we need to think about is the peripheral neuropathy, which contributes to diabetic foot ulcers, which increase mortality. It's one of those things that's always struck me, over the many years that I've worked in home health care, and this was added into the Oasis in the care plan synopsis, the whole focus on ongoing foot assessment and education. If we really focus on this, we have such opportunity to reduce the incidence of diabetic foot ulcers, because we know as home care nurses that one little sore on your foot and the patient may face months of wound care, may potentially end up with an amputation, and as noted here, mortality risk goes up as well. So the more preventative things we can do, the better, because these patients often do not feel. So we need to make sure that they're checking their feet. We need to look at the footwear that they're wearing, things that might contribute to causing an open sore on that foot that they might not initially feel. High glucose levels increase the risk of infection. And then assessments to do when any wound is present. We're going to look at, what is their long-term history. Smoking status, of course, is important and challenging for us to address, but healthcare providers need to address that. And some patients may be ready to stop smoking, may be ready to consider that. And the more we reinforce that, the research does show we can make a difference. And then we've got the labs that we need to take a look at. The hemoglobin A1C, as I mentioned, CBCs, C-reactive protein is reflective of inflammation, as is the sedimentation rates, BUN and creatinine, reflective of hydration as well as kidney function as well. So as nurses, we want to integrate and understand, where they're at in terms of their laboratory profile as well as their physical assessment. So really looking at that whole picture. The ankle brachial index, I don't know how often you're doing it. I don't think our nurses are regularly doing that, but we know that when you compare the ankle blood pressures to the brachial blood pressures, normally it should be about a 1-to-1. They should be approximately the same. But when that blood pressure at the ankle is significantly lower, it is predictive of peripheral arterial or peripheral vascular disease. So it's an important screening piece in helping us to understand the risk that that particular patient has. And again, looking at their footwear is extremely important. Home care treatment for pressure ulcers. This in and of itself, of course, is a lecture for probably hours looking at all of the options out there, but we do need to not only treat the pressure ulcers, but really focus on relieving the source of pressure in the contributing factors, as I mentioned earlier, whether that be moisture, nutrition, etc. Treatment is going to vary. It's interesting, as I look at evidence-based practice, we know that moist wound healing is evidence-based practice, and we still struggle with some of the wet to dry dressings out there, but there's a lot of different options for wound care. It's really kind of beyond the scope of this particular presentation, and it's a complex area, and we're often working with wound care specialists. But as general nurses out there, we need to be assessing skin and looking at ways to reduce the incidence and promote, healing, hoping that we can ultimately heal that ulcer, and then hopefully, if we have all of our preventative things in place, reduce the risk of it occurring again. Cardiovascular assessment, when we look at both of these patients, cardiac abnormalities are present. When we look at risk factors for stroke, just overall risk factors, looking at our general population pre-stroke, overweight, low activity, alcohol, drugs, and high blood pressure are all major factors. And of note, if you look at the Mayo Clinic website, the risk of stroke begins when the blood pressure readings begin going above 1 over 120 over 80. So So I think we have a lot of issues out there with poor blood glucose control. Now, the guidelines for patients with diabetes, for example, are a little bit higher now, but focusing on blood pressure management is extremely important as a preventative measure for disease management. And we know cholesterol needs to be looked at, and cardiovascular diseases are going to contribute to the increased risk of stroke, both at the time and after the first stroke. We continue to have that risk, obviously. In patients with diabetes, poor glycemic control, we know increases the risk of the macro as well as the microvascular problems. Heart disease, overall heart disease, peripheral vascular or coronary artery disease, as well as retinopathy and nephropathy, neuropathy, etc. So this is why we want to pay attention to that A1C level and try and get their blood glucose under control and work with our patients. Neurological assessment. There's a very nice guideline out there from Canada, actually. It's the Registered Nurse Association of Ontario, and I heard that we have one nurse from Canada in this presentation, and I know you don't use Oasis, but a very nice guideline entitled Stroke Assessment Across the Continuum of Care. And they provide a lot of guidance in terms of what we should be assessing. And they state very clearly that nurses in all practice settings should continue to monitor neurological status on an ongoing basis for any changes in vital signs, level of consciousness, orientation, motor strength, balance and coordination, for example, checking hand grips, leg raises, being able to shrug the shoulders, checking pupils, any changes in speech and language. They also recommend blood glucose monitoring as well for patients who have diabetes along with stroke. So nice guideline there if people want to look at that. It's rnao.org, and you can have access to numerous guidelines that they've put together that are all evidence-based. I really like that source. For patients with diabetes, as I talked about before, peripheral neuropathy is a problem, and when patients don't feel, they're more likely, they don't know if they've stepped on something. That's why it's so important for them to assess their feet and wear the right footwear, and we do have tests to assess for that. Universal for all patients, and these are things we do in Oasis, which give us, again, some sense of, what are the risks. We look at risk of hospitalization, which is one of the Oasis items, and, some of the things that are listed in that item, recent decline in mental, emotional, or behavioral status, history of multiple hospitalization, history of falls, 5 or more medications, frailty indicators, anything else. There's an other category there. But we want to be able to call out and say, this person has an increased risk of hospitalization, to help us have that awareness and to make sure that we're putting into place, all of the things that we can do to hopefully mitigate some of those risk factors. We look at their overall status, in terms of their stability. Do we feel that, they're likely to return to stability or likely to remain in fragile health, for example? So we have to make some judgments there, and I think that's a tough one to complete sometimes. We look at risk factors, for example, smoking status, diabetes, again, helping us to identify those things that we can possibly work on with patients. Vaccinations are important. Flu vaccines, we know, can reduce the mortality and morbidity in our chronically ill patients. So a lot of focus. We've been collecting that as a process measure for a number of years, and it's collected at other sites as well, acute care, long-term care. I just was at the Association for Practitioners in Prevention Control and Prevention last weekend in California. Listened to an excellent presentation on the importance of our vaccinations, and somehow we've gotten away from a lot of things, and now we have some chronic diseases or some acute diseases coming forth again. But there is a lot of fear out there, and it's up to us to really provide the informed education to our patients, and this definitely will help them. Falls risk assessment, I'll talk a little bit more in a minute. overall status is assessed. And one of the things that's, to me, notably missing in Oasis is the nutritional risk and risk for dehydration. I think most organizations, because Oasis is a structure, but you build in your other assessment items into the Oasis, most organizations will build in a nutritional risk tool as well. But that's very important with these populations that we're capturing that. Looking at falls risk, 8th leading cause of unintentional injury for older Americans. The source of this information is from the consultgerryn.org website. A lot of valuable information, evidence-based there. But when we look at risk factors, it may be intrinsic risks such as they have cognition problems, perhaps they have visual problems, they have gait or balance impairment, perhaps they're on high risk, or contraindicated medications which may put them at higher risk. And we need to know what those are. And then there's the extrinsic risks, as use of assistive devices and perhaps not using them properly, inappropriate footwear, use of restraints. The big focus is to not restrain people because restraints people try to escape them are more likely to fall. Non-sturdy furniture, equipment in the home, poor lighting, uneven slippery surfaces. We have a lot of risk factors as we look in the homes because they're not necessarily designed for that person who may have chronic illnesses and functional limitations. So we have to look at, are there things that we can do? Other causes may include orthostatic hypotension. That should be routinely assessed. Arrhythmias, infections, weakness, syncope, hypoglycemia, neuropathy medication. So a lot of causes, and we need to really look at falls risk among our home health population. When we look at patients with stroke, as we assess for their falls risk, we want to look at their ability to comply with the treatment regimen against smoking status. It goes a little bit beyond just the falls risk, but what is the family and caregiver's ability to do the necessary home care duties? Are they able to assist that patient adequately? We may provide some aid support for ADLs, but as things evolve, we know they can't necessarily stay in there forever. So how do we, facilitate that care to support their needs in the face of some functional limitations? Looking at diabetes in particular, this is the American Association of Diabetic Educators guideline. They identify 7 behaviors that patients need to achieve optimal blood glucose control. And we know it's not as easy as just a list here, but focusing on healthy eating, plate method, carb counting, increasing activity and monitoring blood glucose during that activity, the self-monitoring related to feed as well as blood glucose levels, taking medications correctly, and having plans in place if they forget meds. And the reality is the most common reason the patients don't necessarily adhere is they simply forget. So, sometimes if your normal routine is altered in some way, you may forget to take your medications, and have plans in place. And then healthy coping and how do we reduce the overall risk. So when we look at good glycemic control, adhering to meds, the self-monitoring, every patient should know the ABCs. They may not be able to know everything and the rationale for everything. I think that's up to us to really work with patients to, prioritize what they really need to know, what they are capable of understanding, given that some may have cognitive limitations. But your ABCs would be your A1C level, your blood pressure, and your cholesterol. They should know that these things are really important in reducing the risk for complications. Knowing what to do in the event of hypoglycemia. One of the things is the rule of 15, and I was doing some sessions with the nurses in my organization a couple of months ago, just kind of small groups looking at what we're doing great in terms of reducing hospitalization and what we're sometimes missing. One of the things I saw in the records was patients with hypoglycemic episodes and kind of an over-treatment, giving them way too much. And so I talk to them about the rule of 15, which is established in the literature. You can Google that and find, information on it. But basically it is to, limit it to 15 grams okay, which would be like a half a glass of orange juice, not a full glass, 5 lifesavers. 15 grams and check in 15 minutes until the blood glucose gets up to normal. So what I was seeing was a real overshooting. Okay, their blood sugar is really low and they're giving them, tons of carbs, and all of a sudden the blood sugar is 250. We don't want to do that. So really, helping patients to understand how to manage that, and then critically looking at that situation and saying, why is this patient having so many hypoglycemic episodes? What's going on in terms of their overall med management, dietary management? Are they not eating enough? They just came home, they don't have a good appetite, they're still on the same amount of insulin, for example, or maybe they're on multiple drugs, but really looking backwards too to see, is there something that we're really missing here, and to reduce that risk. And this takes a lot of kind of critical look at the overall plan of care. My belief is that no patient should go into the hospital with hyper or hypoglycemia, that we should be able to manage that in the home. It may take extra visits. It may take a real good relook at how they administer their insulin. Are there some errors there? What's really going on? And of course, all of the other things that we know we need to do listed on the slide here. Working effectively with patients and families, coaching being the key. And this too is a lecture in and of itself. But we're not just teaching patients, we're not just providing them with information, but we have to help them to learn how to change. And one of the things we have to do is really kind of promote their self-efficacy, which is really just defined as the level of confidence in the ability to do something. If they don't feel confident, they're not likely to do it. And we have to look at, their readiness to change. Perhaps they're not willing to do everything. Diabetes, for example, is an overwhelming disease to manage. I think any of us would be challenged, but maybe starting with small steps and build confidence in it. Perhaps they don't want to check their blood sugar. Perhaps they're willing with some encouragement. Let's look and see if you just check it like 3 times a week. Start there, but start with small goals and build on them, and use effective teaching learning strategies. Teach back is all over the literature, and it is very effective. And some nurses struggle with that because it feels like, oh, we're testing the patient, asking them to tell us back. But we're not testing the patient. We're really testing, did we effectively educate them? Are they able to repeat back, say, key things? Maybe it's, signs and symptoms of hypoglycemia. Patient can repeat back. I know that my blood sugar is too low when I get dizzy and sweaty. And if that happens, I will do this. Keeping it really simple and making sure that they can actually reflect back on what you have taught them. There's a real skill to that. This is just more from the ADDE7, risk reduction and coaching. Again, building confidence and skills, looking at, short-term goals that are achievable, as I mentioned previously. When we're looking at oral and enteral care, as I mentioned earlier, we don't necessarily capture this in the Oasis, but we really do want to focus on these issues. Some patients after stroke may require tube feedings, and this will require a pretty extensive plan of care and a lot of education. They may have swallowing problems. Probably we may have speech and language therapy working with them as well on some of that. And we want to look at, their oral care as well. Particularly with patients with diabetes, because we know if they have periodontal disease, that's going to affect their glycemic control as well as the risk factor for cardiac events. If a tube feeding is present, we need to make sure that everything is being done correctly, that they're getting adequate calories as well as adequate fluids in the diet as well. And that means we're, as home care nurses, we're not dietitians, but we'll be looking at the dietitian's plan of care and perhaps collaborating with the dietitian if there's any questions there. And it may be, going back to the acute care organization that discharged them, because many of us don't have a dietitian on board. And when we're looking at, diabetic patients, similar coaching if they're using an insulin pump. And that, again, requires a specific area of expertise beyond the scope of, what we're talking about in today's presentation. But something that we know that we would need more understanding about to be able to coach them. It's not something we typically do that much. They usually have a specialist working with them in that area. Pain and depression assessments, as I mentioned earlier, the importance of these is often underappreciated, and depression is extremely prevalent across our patients with chronic illness. That's been pretty well documented. And I think sometimes it's difficult to ask those questions. Our comfort may be limited. And I think even on that first visit, you're just getting to know that person, and then you're asking them these questions about depression. You may feel less comfortable. Sometimes it is helpful to move it to the second visit, as you feel a little bit more of a relationship with that person. But we want to do that, and it just is a screening. The two questions that we ask, that are included in the Oasis, are part of the full PHQ. We just look at the two questions. But we need to be able to ask those exactly as they exist, and it is a screening tool. And if we have a positive results there, it's something that we need to do information with. Treatment, we're not going to get really far in self-care management if we're not looking at some of the underlying problems such as depression or pain that are going to affect their ability to manage their self-care. So as in the red letters in the box state, the presence of either of these is a potential barrier to treatment adherence, wound healing, self-management, and just optimal quality of life. The pain assessment, I have a little bit more information on completing this in relation to Oasis, but we need to use a standardized pain assessment tool that's scientifically tested and validated. And typically we use the 0 to 10 scale. The FACES scale is sometimes helpful in patients who may have some cognitive limitations or who respond better to it. Sometimes just using a variety of scales to really help that patient tell us better where their pain is at is helpful. There's a pain ad scale that's used for patients who have some degree of dementia. So we have different tools available out there. Like I said, the 0 to 10 is most commonly used. We need to identify severe pain. And of course, CMS doesn't endorse any specific tool or tell you what severe pain is. You would have to use a scoring system for that standardized tool. And it's important to do a thorough pain assessment, not just the pain rating per se, but what is the quality and characteristics of the pain, when does it occur, and recognizing that patients with either stroke or diabetes may have some neuropathy that can lower their perceived levels of pain, or they may have neuropathic pain, which is challenging sometimes to manage in these patients. But we need to understand, what is the type of pain that they're having. Again, this in and itself is a significant topic to address, and we look at frequency of pain as well. Pain and stroke patients, just to note that this is addressed again in the Registered Nurses Association of Ontario. The pain is a pretty frequent problem in post-stroke, and hemiparetic shoulders is a risk, and it's caused by spasticity of the shoulder muscles and subluxation of that joint, and that can be quite painful. So that risk exists, and that usually comes a little bit later after stroke. So it's preventable, with range of motion exercises and positioning. And this is where we need to get those therapy consults in place so we can, again, mitigate the risk of the patients developing this condition. Neuropathic pain, as I mentioned before, is a fairly prevalent thing among patients with diabetes. You see a lot of commercials on TV, obviously, pushing certain medications to treat it, but the problems with neuropathic pain are really kind of highlighted in some of these commercials. And with this decreased sensation and pain, again, you have the risk of developing foot sores. We talked all about foot self-exams before. Depression screening, again, just a little bit more information here. The need for thorough assessment and early intervention, and the need to really, collaborate with the physician for patients at risk. Assessing the need for strategies, other services, perhaps, our MSW services may be helpful, but I think it's really important that, physicians are on board with our screening assessment, and we look at potentially treating and monitoring the response to treatment within the home care episode. So I'm kind of closing up here, but one of the things I wanted to talk about is just the nursing process. I've cited at the bottom the Home Health Nursing Scope and Standards of Practice from the American Nurses Association. That was a 2009. I was actually one of the committee members on that version, but we have the new version we completed the beginning of this year. So sometime in July, I understand it will be available for purchase. So the 2014 Home Health Nursing Scope and Standards of Practice. Just to remember that when we're doing our care, the nursing process is the framework that we follow. And it really is helpful. We all learned it in school, but sometimes I think we jump from assessment to implementation, and we don't do enough with identifying our nursing diagnoses or problems. And that includes those risks, those at-risk problems. If we don't identify they're at risk for dehydration or at risk for skin breakdown, we're not going to put forth interventions in the plan, again, to reduce the risk for those problems. So our 6 key steps in the nursing process are assessment, and we use Oasis, but it's beyond Oasis. Identifying nursing diagnoses, identifying expected outcomes, planning, implementing, and evaluating. And it's not necessarily a linear process. I mean, we're constantly evaluating and we're constantly even modifying our plan, probably based on new problems or issues that come up, or perhaps our expected outcomes need to be adjusted somewhat. But to me, I would love it if every nurse would really read our scope and standards of practice, and it is available from the American Nurses Association. So just to summarize, the Oasis C is mandatory, but it's also an important tool used in assessment and planning for home care. It's helpful to complete the Oasis over a couple of visits for patients with stroke and diabetes, and probably a number of other illnesses as well, depending on the complexity. Med reconciliation and physical assessment are top priorities. And the Oasis assessment helps to identify key nursing diagnoses, including those actual problems. We've got a wound and we're going to treat it, but also the potential problems. Their risk for falls, their risk for developing pressure ulcers, etc. The importance of pain and depression assessments are often underestimated. Both pain and depression can cause problems with healing, motivation, and adherence, as well as other complications. So concluding, and I'm speeding up a little bit here to be able to address any questions you may have, but the Oasis C is a powerful reporting, care plan, treatment, and communication tool for home health nurses. And we focused on nursing here, but certainly with our other professional disciplines as well. We're all using it and we're all working together. The importance of teamwork cannot be underestimated. So as far as continuing education credits go, just to reiterate that you can obtain 1 contact hour of CE by going to www.sextesting.com/SP. You'll need to complete a post-test and the evaluation form. Upon successfully submitting these, you'll be able to print out your certificate of completion, and SACS Communications, the provider, is approved by the California Board of Registered Nursing, and their provider number is listed. And just a final thank you to the Home Care Division of Covidien for supporting our webinar today. Thank you. Just to, again, thank you all for attending today, and we do have approximately 10 minutes or so to address your questions related to my presentation today. Thank you.
Lisa, thank you so much for an excellent presentation, and we will now move into taking some questions from our audience. The first question here is from Sharon. Can you please explain the hemoglobin A1C level?
Thanks. That is a good question. And I think a lot of nurses might not truly understand this, but the A1C level, it's also called a glycosylated hemoglobin. It is indicative of the patient's blood sugar control over the last 2 to 3 months. What happens is glucose in the blood binds to hemoglobin to form a hemoglobin complex, but the normal lifespan of red blood cells is about 90 to 120 days. So the A1C is only eliminated when those red blood cells are replaced. So when you're looking at the A1C, it's reflective of approximately 3 months of blood glucose levels. When you look at those individual, readings, they're important, but you want to look at that overall control. The recommendations in general are the A1C is done every 3 months, when blood glucose is elevated during treatment changes, etc. For stable patients, at least every 6 months. I personally would have great difficulty actually managing a patient with diabetes unless I knew their hemoglobin A1C. So I think that's extremely pertinent information. We should have the recent level on all of our patients who have diabetes. It just assists with our overall management and acknowledgement of their control.
Well, thank you. And Alexandria has a question. You mentioned the importance of checking the orthostatic BP as an element of a falls risk assessment. How is this best done?
Oh, another great question, and something that I think a lot of people aren't necessarily understanding the best way to do that. There is a recent, evidence-based recommendations, actually from the Emergency Nursing Association, Journal of Emergency Nursing. They put forth some guidance in 2012, but there's a lot of research over the years. Bottom line is, though, the best practice for checking orthostatic blood pressures is to have the patient lie down for at least 5 to 10 minutes. You check your blood pressure and pulse while they're lying down, and then you have the patient stand up if they can. If they can't, it won't work. And then you wait 2 to 3 minutes before checking the blood pressure in a standing position. It's important to recognize that supine to standing is much more accurate than supine to sitting to standing. So the gold standard is lying down to standing, and you're going to assess for symptoms such as dizziness, lightheadedness, sweating, pallor during the procedure. Certainly if there's symptoms, we would assist them to lie down. But orthostatic hypotension would be really defined as a systolic blood pressure drop of more than 20 millimeters mercury from lying down to standing, a diastolic drop of more than 10 millimeters mercury, and an increase in heart rate of 20 or more per minute. So hopefully that clarifies that. That's something we actually, put forth, in the education for our nurses and put it in kind of like a handy tool on their laptops to refer to if there's any questions. But accuracy in doing these assessments is extremely important in communicating that information and identifying, obviously, the risk for falls.
Okay, thank you. And Jamie has a question. What is the average time that you recommend spending with a patient during this initial visit?
That's a good question too, and there's no exact answer for that. I think you really have to gauge it, based on that patient's condition on that first visit. Many times patients, they've been in the hospital for a period of time, they haven't slept well, they're fatigued, they've had complications, and their tolerance for having you in the home might be somewhat limited. I would say in the old days, ideally, take maybe an hour and a half to get through everything. So you have to assess financials and all that kind of stuff too. But, if that patient is not tolerating you being there that long, perhaps it might only be 45 minutes and say, well, why don't I, I'll come back the next day and finish things up. So I think it's very individualized. There may be patients that really want you there for a longer period of time, but I think oftentimes they really do have maybe limited tolerance for extremely long visits. And we have to be efficient, as we're, collecting data and assessing. And there's a lot of skill to that as well.
Okay, and Brenda has a question. When you divide the admission over 2 visits, are both of these visits chargeable?
Yes, they're definitely chargeable.
Okay.
As long as the patient meets the criteria for Medicare, requiring skilled care and homebound and all of that, absolutely, they are both chargeable. And as I mentioned earlier, technically you have 5 days to, close down your Oasis. Now, you would use your Oasis completion date. If you complete everything by the 2nd visit, that would be your Oasis completion date. But yes, definitely.
Okay, and Jamie has another question. In your experience, if there is a PT-only admission, meaning no nursing ordered, does the PT do the Oasis, including medication reconciliation, or does an RN complete Oasis?
The PT needs to complete the Oasis, boy, and I'd have to go back to the exact guidance in the Oasis manual for that. I believe that you can, the PT can consult, with a nursing person in completing some of that information there. But the PTs really, physical therapists and home care take a very holistic role in looking at everything, including the medication management. So they are doing the medication reconciliation piece. If there's some questions related to that, I know that they can consult with the nurses. But without taking the time to pull out my manual here, I would refer to the Oasis guidance on that item because I know there's something in there.
Okay, and I think that is all the time we have for questions today. I do want to thank you very much for your time, Lisa. The material that you've covered with us today is vitally important in the home care of our diabetic and stroke patients. And I'd like to thank each and every one of you, our guests in the audience this afternoon, for your time and your thoughtful attention. And with that, it is time for us to say farewell. Take care, everyone, and bye for now.